Hi everyone. Okay, we're going to discuss myeloid neoplasms and lymphoid neoplasms. Okay. Alright, so before we get started, it's really important to understand the lineages. So we have our stem cell in the bone marrow, can go two different routes. One, it can go a myeloid route. Two, it can go a lymphoid. Alright, lymphoid will make your B lymphocytes and your T lymphocytes, while myeloid will make your megakaryocytes, platelets, erythrocytes, red blood cells, myelocyte, myeloblast, monocyte, eosinophil, neutrophil, basophil. So basically your leukocytes. So again, stem cell can go two ways: lymphoid, B cell, T cell, or myeloid, which makes all the rest, your platelets, red blood cells, leukocytes. Alright, so when we classify our leukemias, we're going to classify them in two ways. One, myeloid, or they can go the separate route and be lymphoid. So if it's a myeloid leukemia, it's going to be a problem with something on this side. If it's a lymphoid leukemia, it's going to be a problem with the B lymphocyte or the T lymphocyte. Earlier we talked about acute and chronic. Acute and chronic are descriptions. They're just adjectives. The way we actually do stuff is myeloid and lymphoid, kind of like gram-positive and gram-negative. Now, a myeloid leukemia can be acute. So again, it's a description. So acute myeloid leukemia will be quick onset, while you can also have a chronic myeloid leukemia. Same for lymphoid. You can have an acute lymphoid leukemia and a chronic lymphoid leukemia. So acute and chronic are just descriptions. Okay, with that understood, let's dive into myeloid neoplasms. So myeloid, we're going down the myeloid lineage, right? So the first one, there's three myeloid neoplasms that we're going to learn: acute myeloid leukemia, myelodysplastic syndrome, myeloproliferative neoplasms. Right? So we'll start with one and work our way across. Acute myeloid leukemia. So acute myeloid leukemia, the definition is we're going to get stuck somewhere in the myeloid lineage. Alright, so let's get back to our chart. So here's our myeloid. We're going to only look at the left side of this chart. In acute myeloid leukemia, we're going to get stuck somewhere. We can get stuck here. We can get stuck here. We can get stuck here. Alright? Now, what the key diagnosis feature is, no matter where we get stuck or even get stuck here, we are going to have a lot of immature myeloid progenitor cells. We're going to have a lot of these immature myeloid cells, and these are called blast cells. So anytime the bone marrow has more than 20% of these blast cells, we know it's acute myeloid leukemia. Alright, so it's a trigger word. So let's go ahead and take a look at what this blast cell actually looks like. Alright, so here we have the blast cell. You can see the cytoplasm is all very small on the side, and well, the big grain take up the rest of the space. Alright, and then within this, you can see this hour rod. This is also another trigger word of acute myeloid leukemia. So, acute myeloid leukemia, if I say greater than 20% blast cells or hourglass, you know it's acute myeloid leukemia. And what are blast cells? Blast cells are immature myeloid cells, progenitor cells. Okay? Now, let's go back. So, anytime we get stuck somewhere here, or somewhere in this myeloid lineage, what's going to happen? We're not going to be able to produce megakaryocytes or platelets, leaving us with thrombopenia. We're not going to be able to produce red blood cells, leaving us with anemias. We're not going to be able to produce, leaving us with leukopenias. So what are the symptoms you come in when you have an acute myeloid leukemia? When you have an acute myeloid leukemia, you're getting stuck somewhere in that myeloid lineage, so you can't make those myeloid final products. So you're going to be tired, fatigued, because you don't have red blood cells to make anemia. You're going to get a fever because you're not able to make those leukocytes. You're going to bleed because you're not able to make those platelets. Okay. Now, we said earlier we can get stuck here, we can get stuck here, we can get stuck at many different places. Now, each of these places has a name, and the way we use to classify this is MO through M7. The World Health Organization incorporates this system into theirs, which will make more sense as you finish this video. You can take a look at that on the actual lecture slide. So, let's start with MO. We have a new chart which actually makes more sense for this. It's not as pretty, but here. So, MO is minimal differentiation of the progenitor. M1, there's no maturation of the progenitor. M2, there is a maturation of the progenitor. Alright? So that's how we can differentiate where we're getting stuck. MO is the first one, and that's going to be the highest up. M1 will be further down. M2 will be even further down after maturation. The way you can try to remember this is think about us starting med school. MO was the most immature. M1, we were still not mature. And M2, we're starting to get mature, at least for those of us that are losing their hair. Alright, so the last important thing about M2 is you can have this translocation on your chromosomes. 20% of the people who have M2 will have a translocation on the chromosome 8 and 21. Alright, moving on. M3 is acute myeloid leukemia promyelocyte. So it sounds really fancy, but let's look into it. Acute promyelocyte leukemia. It tells us exactly where it's going to be. Promyelocyte. Promyelocyte is actually what the progenitor to neutrophils. So M3, we're getting stuck right here, right before. We're not able to make neutrophil, which will leave us with the neutrophilia. Now, what is causing this? What's the pathogenesis? The pathogenesis is on chromosome 15 and 17, you get a combination, a translocation. On chromosome 17, there's retinoic acid receptor alpha, which we could just call RARA, and on chromosome 15, there's a PML gene. These two join and fuse because there's the translocation between them, and you get this PML RAR alpha gene, protein. Now this blocks us here. The way we can treat this is we give allotrans retinoic acid, chemotherapy, and arsenic trioxide, and we're able to degrade this protein. If we degrade this, all of a sudden we can continue to make neutrophils. Alright, now one of the risks is when we start treating people, we actually send them into DIC. And DIC, we learned from earlier, is the disseminated intravascular coagulation, one of the bleeding disorders we had learned. Alright, M4 is acute myeloid leukemia myelomonocytic, right? Myelomonocytic. So we're getting stuck between the myeloblast and the monocyte. So it's somewhere up here. Now the two things to know about M4 myelomonocytic is you can have a 11q23, which is associated with DIC, and you can have an inversion in chromosome 16, which is linked to eosinophilia. And it's actually beneficial to have the inversion chromosome 16 linked to eosinophilia to give a better outcome. Okay, so let's quickly review. We have MO, M1, M2. They deal with the early progenitors, and they go in order of maturation. MO, minimal diff. M1, no maturation. M2, you have the maturation. Now let's look at M2, M3, M4 is where we have the chromosomal differences. M2, you have the translocation between chromosome 8 and 21 in only 20% of the patients. M3, all the patient, 100%, have a translocation with 15 and 17, which joins your PML, which is on 15, and your retinoic acid receptor alpha, which is on 17. M4, you can have inversion in 16, which is linked with eosinophilia, which is a better outcome, and 11q23, which is linked with DIC. M5 is right here. It's acute monocytic. So acute myeloid leukemia monocytic, you're not able to make this. You get stuck here. M6, you have acute myeloid leukemia erythroleukemia. You get stuck right here. You're not able to make erythrocytes. So in your bone marrow, you're going to have greater than 50% of erythrocyte progenitors. M7 is megakaryocyte, so you're not able to make platelets, so you're going to get stuck here. Alright, so now we want to stain for these. There's a couple different stains we have. There's, for immature, we can do Sudan black and myoperoxidase, and immature is going to hit our ones we talked about earlier, right? MO, M1, M2, M3. Myeloperoxidase and Sudan black are immature. Mature, we have specific esterase. Specific esterase are going to do our later further ones, past M1, M2, M3. And then we have a monocytic, which makes sense, is just going to go for M4, M5, because those are the ones that deal with monocytes, right? Monocyte, monocyte. So, let's go ahead and take a look at the stains. SBB, Sudan black B, again, immature. MPO, myeloperoxidase, again, immature. Specific esterase, a little more mature. Non-specific, go straight for monocytes, M4, M5. Alright, and it's also noticeable to note that favorable outcomes, so better outcomes are linked, again, to all those translocations end up with better outcomes if you're diagnosed younger and if it comes on right away. There's no preconditions, right? Now you have a worse outcome if you're below the age of 2 when you get diagnosed, you're over 60, or if you prior have had myelodysplastic syndromes. I reviewed acute myeloid leukemia. Acute myeloid leukemia, you get stuck somewhere in the myeloid lineage. You get stuck. Keyword stuck. Diagnosis factors: 20% blast cells in the bone marrow, and you have hourglass. Alright, you have the classifications MO through M7, plus a couple in the World Health Organization, and you can go ahead and look at the symptoms and the stains in the lecture. Okay, let's move on. So we talked about acute myeloid leukemia, where you get stuck. Now let's talk about myelodysplastic syndrome. In myelodysplastic syndrome, again, your bone marrow is being replaced, and instead of getting stuck somewhere, you have a multipotent stem cell that can differentiate. It can make it can continue the process down. However, whatever the final products are going to be useless. So if you're making useless products, your functional availability is actually not there. So you're going to have a cytopenia. You're going to have a lack in something in that lineage. Alright? So you're not getting stuck, but you're making something, but it's not working. So again, you're going to have a decrease in something in this area. Alright, so, and the pathology behind this one is, they actually don't know. They assume it's as you get older, you get genetic injury. Alright, so, refractory anemia. The myelodysplastic syndromes, we have a couple different categories within it. Refractory anemia, it names exactly the problem. You have an anemia. So, you're not able to make erythroid cells, which are red blood cells. So you have an anemia. 2. Refractory anemia with ring sideroblast. Exact same thing as refractory anemia, but now you're also going to see ring sideroblast. 3. Refractory cytopenia with multilineage dysplasia. Okay, let's break this word down. Alright, cytopenia means from the video we watched earlier, you're lacking something. Neutrophils, eosinophils, you're lacking something. Okay, multilineage dysplasia, that means you're lacking something in a couple different lineages. So we have the myeloid, which can go to red blood cells, platelets, can go to leukocytes. You're lacking something in 2 or 3 of those different lineages, the different pathways it can go. So, refractory cytopenia with multilineage dysplasia just means you are lacking something in a couple different lineages. It's just an addition to this. 4. Refractory anemia with excess blastocytes. Sorry, refractory anemia with excess blast. RAEB. That's how we get this acronym, RAEB. So there's 2 subcategories in refractory anemia with excess blast. RAEB1, where you only have 5 to 10 blast, and RAEB2, which is 10 to 20 blast. What are blast cells? Remember from earlier, blast cells are here. Blast cells are the immature myeloid cells. Now, as you get up to 20%, we already talked about, once you hit 20%, what does that mean? That means now you're acute myeloid leukemia, because that is the trigger word. So, if you reach 20%, you're now in the acute myeloid leukemia. What does that mean? Myelodysplastic syndromes can become acute myeloid leukemias. Alright? So, here you can differentiate. But if you hit 20% blast, now you're going to get stuck somewhere because you're in acute myeloid leukemia. Alright, moving on, we have myelodysplastic syndrome associated with deletion of 5q, and it's linked with thrombocytosis, and you treat with Revlimid. The last one we have to know is chronic myelomonocytic leukemia. In this one, since you can differentiate, where you're going to get stuck is, sorry, not stuck, you continue to make monocytes, however they're useless. So in M5, if you remember, M5 is acute monocytic leukemia. You get stuck. Why? Because it's an acute myeloid leukemia. Stuck. In chronic monocytic leukemia, same name except it's chronic, you can differentiate because it's a myelodysplastic syndrome. However, this can lead to acute myeloid leukemia, and they can lead to acute. Alright, so how do we calculate the survival rates of people that have myelodysplastic syndromes? Well, what we do is we take the blast percentage, and the blast cells, remember, are the immature myeloids, and we give it a score. The more blast you have, the worse it is, because you go more towards acute myeloid leukemia. So we give that a score. Cytogenetics. Cytogenetics are all these chromosome abnormalities that we have here. Now, a lot of them can be beneficial, so we give this a score too. Cytopenias. The more cytopenias you have, the more things you're lacking, the worse you are off. So we give a score here too. We add it all up and we get a score, and we just basically plot it on a graph, and we see what the average lifespan is if the person's going to be. Now we can treat myelodysplastic syndromes with hematopoietic growth factors. Alright, so myeloid neoplasms. We have acute myeloid leukemias, you get stuck. We have myeloid neoplasms, we have myelodysplastic syndromes where you can differentiate, but you can also lead to acute myeloid leukemia if you hit 20% blast cells. The last one we're going to talk about is myeloproliferative neoplasms. In this one of the lineages is going to hyperproliferate. One of them is going to hyperproliferate and just grow like hell. So the 4 that we have to know. Chronic myeloid leukemia. In this one, the pathology behind chronic myeloid leukemia is you have this Philadelphia chromosome. So you have a translocation with chromosome 9 and 22. Chromosome 9 has an ABL gene, chromosome 22 has a BCR gene. You combine the two, and you get an ABL-BCR fusion protein. This ABL-BCR fusion protein creates a tyrosine kinase. Alright, now the tyrosine kinase actually somehow helps mimic growth factors. So what do you end up with? When you have chronic myeloid leukemia, you're making a bunch of leukocytes. So what's that going to mean is you're going to have an increase in all leukocytes. Now the trigger is you're going to have a basophilia. Now remember, basophilia from the video we learned earlier is an excess in basophils, and we said when you had a basophilia, you had to check for the underlying reason, because this could be it. Now, the way we actually look for it is we use this LAP test. Now, if it's CML, chronic myeloid leukemia, the LAP will decrease. If you have excess leukocytes because you're actually finding an infection, the LAP will increase. So that's how you can tell if it's CML. Now, if CML is left untreated, it can go to the accelerated version. It can then go to blast. And what happens when we have 20% of blast cells? We end up with acute myeloid leukemia. That's why we have this arrow going here as well. Now, chronic myeloid leukemia, some fun facts are it hits the median age of 50. Okay, let's move on. So the second one we have is polycythemia rubra versa. Sorry for the pronunciation. Sorry for pronouncing that wrong. Alright, in this one, we have too many red blood cells. Remember, myeloproliferative, in the name, proliferative. One of these lineages, leukocytes, red blood cells, platelets, something has to grow. In chronic myeloid leukemia, it was what? It was the leukocytes. Again, it's red blood cells. Now, in the chronic myeloid, we had what was the pathology? The Philadelphia chromosome with the ABL and BCR fusion protein. In the rest, 2, 3, and 4, it's all the same. There's a JAK2 gene mutation. And the JAK2 gene mutation somehow lowers the dependence of growth factor receptor. so you don't need as much growth factor for the cells to proliferate. So we have too many red blood cells. 3, thrombocytosis, which is what? Platelets, too many platelets. And again, JAK2 is a pathogenesis. 4, chronic idiopathic myelofibrosis. In this case, fibrosis it takes over the bone marrow. And so you have a pancytopenia. Pancytopenia, all that means is you're lacking in platelets, red blood cells, and leukocytes. So you're asking yourself, what is increasing? Well, what's increasing is within the platelets, you have these granules that are released when you're hurt, and these granules help with wound healing. So the megakaryocytes are making granules. Okay, so let's go ahead and take a look at our chart. In our chart, for myeloproliferative neoplasms, look for the red. All right. If it was chronic myeloid leukemia, you're gonna get excess of all of these. And what do we look for? Excess basophils. Basophilia. That's the key word there. All right. And what was this? This was chromosome 22 and chromosome 9, an ABL and BCR transfusion protein, which makes tyrosine kinase. For 2, we had polycythemia rubra versa. This was increased red blood cells. This was a JAK2 problem. 3, we had thrombocytosis, which is an increase in platelets. This was a JAK2 problem. 4, we had chronic idiopathic myelofibrosis. This also was a JAK2 problem, and this is when we were making, remember, the granules that usually go in platelets. So from megakaryocytes, we're making these granules. Okay, so that sums up the myeloid neoplasms. We had acute myeloid leukemia, which is the worst, myelodysplastic syndromes, and myeloproliferative neoplasms. All right, and so here's the chart. You should have the PDF with you, so you can go ahead and write notes on that as well. Okay, remember, so the 2 different lineages we go down, myeloid and lymphoid. Now we're going to go down to lymphoid. Luckily, lymphoid is a lot nicer. Okay, so lymphoid, we can have acute lymphoid leukemia. Acute lymphoid leukemia is we're going to get stuck here at the lymphoid progenitor stage. We're going to get stuck very early on. So in the bone marrow, we're going to have a lot of immature lymphocytes. All right. Now this is primarily hits kids under 15 years of age. And if we treat when they're between the ages of 3 and 7, we can actually treat with a lot of success. So that's a win for medicine. Alright, and then the pathology is there is some problem with a transcription factor mutation, and it's just going to cause massive proliferation. Now there's a couple different ones, because remember, lymphoid, you're going to make B and T cells. So it can affect it early in the early pre-B cell stage, and that's going to happen in the bone marrow. And if we want to do flow cytometry, we can use CD10. It can affect in the pre-B stage, and we can use CD20, and it can affect the B cell. And again, this is all proliferating. 2, it can affect the T cells. Now, the T cells are actually worse than the B cells, comparatively. Both are bad, right? Now, the symptoms are going to be big lymph nodes and spleen. That's the usual for almost everything. The ones you want to look at is you're going to have a swollen testes, sorry guys, vision blur, and central nervous system involvement. Alright, and now we're going to go ahead and move on to chronic lymphoid leukemia. Let me just make sure I have nothing else for that. Alright, so for chronic lymphoid leukemia, you're going to have a buildup of mature lymphocytes. And so you're going to have a buildup of lymphocytes, and the reason why, the pathogenesis is those lymphocytes are inhibiting apoptosis. They actually have this gene called BC12, which is inhibiting apoptosis. So here it is, pathogenesis, self-inhibit apoptosis. Now, how do we look for this? Now, the diagnosis factor is we can look for these smug cells on the blood smear. So let's take a look at that. Smudge cells. So when they take the 2 plates and they push it again together, you actually rip apart the blood cell. So that's the smug. So that's the diagnosis feature. And they're going to show both CD19 CD19 marker and CD5. So it's a B cell and a T cell marker. This actually also affects more males than females, so that's a win for females. And you're going to see a big spleen and lymphocyte and lymph nodes. Right? Now, the nice thing is the treatment, we don't have any, which is sad, but it usually hits people later on in life. So they usually don't die of this, but they can die with something else. And it can also transform into something worse, like acute lymphoid leukemia and B lymphoma. Alright, so that ends the neoplasm lectures. I hope that helped, and I hope everyone